Your doctor is scheduling tests that could be doing you more harm than good. Right now, millions of people over 70 are going through routine screenings that, according to growing medical evidence, cause unnecessary anxiety, risky follow-up procedures, and sometimes life-altering treatments for conditions that would never have harmed them. And here is the most disturbing part. Your doctor may know this and not tell you, not because of bad intentions, but because the medical system rewards doing more, not doing less. Stay with me until the end, because the number one exam on this list is something almost every American over 70 has done in the last 2 years. A landmark study published in the New England Journal of Medicine found that this particular screening leads to unnecessary treatment in up to 60% of older adults who undergo it. 60%. That is not a small margin, that is the majority. I am Dr. Christopher Hayes, a physician specialized in senior health with over 15 years of dedicated clinical experience. I have helped thousands of men and women over 60 navigate a medical system that was not always designed with their best interests in mind. What I am about to share goes against what many doctors and hospitals tell you, but I have seen it with my own eyes, patient after patient, and I refuse to stay silent any longer. If this information sounds important to you, hit that like button right now. It helps more people over 60 find content that actually serves them. Now let me be clear before we begin. I am not telling you to skip all medical care. Absolutely not. I am a physician. I believe in medicine, but I also believe in informed consent. I believe you deserve to know the full picture before you agree to any test or procedure. And the full picture around certain routine screenings for people over 70 is something very few doctors take the time to explain. Here is what is happening inside the medical system right now. After the age of 70, your body changes in fundamental ways. Your cells divide more slowly. Your immune system responds differently. Many small abnormalities that would have been dangerous at 40 or 50 simply sit quietly in your body at 70 or 80, never growing, never spreading, never causing you a single problem. The medical term for this is indolent disease. And the problem is that our screening tests cannot always tell the difference between an indolent finding and a dangerous one. So what happens? A test finds something. Doctors feel obligated to investigate further. You undergo more tests, possibly a biopsy, possibly surgery, possibly radiation or medication. And what were you treating? Something that was never going to hurt you. Meanwhile, the treatment itself carries risks. Infection, bleeding, anesthesia complications, anxiety, and in some cases, permanent damage. This is what the research calls overdiagnosis and overtreatment. And it is one of the most serious, least discussed problems in senior healthcare today. The medical community has known about this for decades. Yet the screening recommendations often lag behind the science because the system has financial and liability incentives built into ordering tests, not skipping them. Let me walk you through 6 routine exams that deserve a serious second look for adults over 70. I have ranked them from the least problematic to the one that I believe causes the most unnecessary harm, and I want you to take notes because this information could change how you approach your next doctor visit. Before we continue, I am curious. Are you in your 60s, 70s, or 80s? Have you been told by your doctor that you need a screening test recently? Type your age range in the comments below. Let us see just how many of us are in the same situation. Number 6, annual full-body skin checks for low-risk individuals. Dermatology screenings are valuable for people with a history of melanoma, unusual moles, or significant sun damage. But for the average older adult with no personal or family history of skin cancer, annual full-body skin examinations ordered as a blanket routine have very limited evidence behind them. Here is why this matters. The United States Preventive Services Task Force, which evaluates screening evidence rigorously, has repeatedly concluded that there is insufficient evidence that routine skin cancer screening in average-risk adults reduces mortality. What it does do, reliably, is increase the detection of small, slow-growing basal cell and squamous cell carcinomas that, in a 75-year-old, may never have caused any symptoms or shortened life. A study published in JAMA Dermatology found that areas with higher dermatologist density have dramatically higher rates of skin cancer diagnosis and treatment, not because there is more skin cancer, but because more looking finds more things. And finding more things leads to more procedures, more biopsies, and more anxiety. For someone over 70, every biopsy carries a small but real risk of infection and wound complications. Healing slows with age. What seems minor in a younger patient can become a serious issue in an older one. The pro tip here is this. If you have no history of skin cancer, no unusual lesions, and your primary care doctor has not identified anything of concern, ask specifically why a full dermatology referral is being recommended. Ask what the evidence says for your age group and risk profile. Number 5, routine thyroid cancer ultrasound screening. This one surprises most people. Thyroid cancer sounds terrifying, but here is what the science actually shows. The vast majority of thyroid cancers found through incidental imaging in people over 70 are papillary microcarcinomas. These are tiny, slow-growing tumors that almost never spread or cause death. The research is unambiguous on this point. A study published in the New England Journal of Medicine tracked thousands of patients with small thyroid cancers who chose active surveillance, meaning watchful waiting with no immediate treatment. Over 10 years, more than 90% of those tumors did not grow significantly. Most of the patients never needed surgery or radiation. Yet when these findings are discovered, the standard pathway often leads to thyroidectomy, surgical removal of the thyroid. And a thyroidectomy in a 72-year-old is not a trivial procedure. It carries risks of damage to the parathyroid glands, which regulate calcium. It carries risks of injury to the recurrent laryngeal nerve, which controls the voice. And it commits the patient to lifelong thyroid hormone replacement therapy. I saw this pattern play out in my own practice repeatedly. Patients coming to me after an ultrasound found something in their neck, terrified, convinced they had cancer that needed to be removed immediately. And the conversation I had to have with them about watchful waiting was one of the hardest conversations in medicine, because it goes against everything we are conditioned to believe about cancer. For adults over 70, the evidence increasingly supports active surveillance over immediate intervention for small thyroid findings. Always ask your doctor whether watchful waiting is an option before agreeing to surgery. Number 4. Echocardiograms ordered routinely without symptoms or risk factors. Echocardiograms or heart ultrasounds are extraordinarily useful diagnostic tools when you have symptoms like shortness of breath, chest pain, palpitations, or a known heart condition. But when ordered routinely as part of an annual checkup in an older adult with no cardiac symptoms and no significant risk factors, they create a problem that cardiologists call incidentaloma, which is the discovery of incidental findings that require further investigation. Here is what happens. After 70, the heart changes, valves thicken slightly, chambers remodel. Small degrees of valve leakage, called regurgitation, become extremely common. So does mild diastolic dysfunction, which refers to the heart stiffening slightly during its relaxation phase. These findings are present in the majority of people over 75, and in most cases are completely normal for the age. But when a test report says mild mitral valve regurgitation or mild diastolic dysfunction, patients and sometimes even physicians treat it as something requiring action, referrals to cardiologists, more tests, follow-up echocardiograms every 6 months, medications with their own side effects. A study published in the Journal of the American College of Cardiology found that routine echocardiography in asymptomatic older adults leads to a cascade of follow-up testing and intervention with no demonstrable improvement in outcomes. In other words, all that additional medical care produced no measurable benefit for patients who felt fine to begin with. If you are over 70 and your doctor wants to order an echocardiogram, ask directly, do I have symptoms or risk factors that specifically indicate this test? What finding do you expect to find, and what would we do differently based on the result? Number 3, Pap smears and cervical cancer screening after 65 or following hysterectomy. This one is important enough that it affects millions of women, and yet the overscreening continues year after year in primary care offices across the country. The evidence here is among the clearest in all of medicine. Women over 65 who have had adequate prior screening with normal results have an extremely low risk of developing cervical cancer. The human papillomavirus, HPV, which causes virtually all cervical cancers, is acquired through sexual activity earlier in life. By 65, most women have either cleared the virus, developed adequate immune response, or have been screened adequately to rule out persistent high-risk infection. The United States Preventive Services Task Force, the American Cancer Society, and virtually every major medical organization agree. Routine cervical cancer screening should stop at age 65 for women with a history of adequate normal screenings. Women who have had a total hysterectomy removing both the uterus and cervix for non-cancerous reasons do not need pap smears at any age after surgery. And yet a study published in JAMA Internal Medicine found that over 50% of American women over 65 are still receiving pap smears. Over 30% of women who have had hysterectomies are still being screened. That is tens of millions of unnecessary procedures per year. Why does this matter clinically? Because abnormal pap results in older women are frequently caused by tissue changes from menopause-related estrogen loss rather than cancer. Those results then trigger colposcopies, biopsies, and significant anxiety in women for whom the risk of cervical cancer is genuinely minuscule. I remember Patricia, a 71-year-old retired school teacher from Philadelphia. She had been getting annual pap smears her entire adult life. Her gynecologist had her come in every year without discussing whether it was still necessary at her age. One year, the result came back with a minor abnormality. Patricia spent 6 weeks convinced she had cancer. She underwent a colposcopy. She lost sleep. She told her daughter. Her daughter flew in from out of state. The biopsy showed benign atrophic changes from menopause. Nothing more. When she came to see me afterwards, she was shaking. She said, Doctor, 6 weeks of my life, 6 weeks thinking I was dying. Was any of that necessary? The honest answer was no, it was not. And that conversation changed how I approach screening discussions with every patient over 65. This was not a failure of medicine. It was a failure of communication, a failure to give Patricia the information she needed to make an informed choice. And you deserve that information too. If you are finding this content valuable, please hit the like button and subscribe to this channel. Every week I share straightforward health information designed specifically for adults over 60, and share this video with a friend. One conversation could prevent weeks of unnecessary worry for someone you love. Number 2. PSA blood tests for prostate cancer screening in men over 75. This is one of the most controversial areas in all of preventive medicine, and I want to walk through it carefully because the stakes are high and the evidence is genuinely complicated. The PSA test, which stands for prostate-specific antigen, measures a protein produced by the prostate. Elevated levels can indicate prostate cancer. They can also indicate prostate enlargement, inflammation, or infection. The test is far from perfect. It has a high rate of false positives. Here is the central problem for men over 75. Prostate cancer becomes extraordinarily common with age. Autopsy studies have found that more than 70% of men in their 70s and 80s have some degree of prostate cancer present in their body. The vast majority of those men died of something entirely different, with no symptoms attributable to the prostate at all. The United States Preventive Services Task Force, after reviewing all available evidence, recommends against PSA screening for men aged 75 and older. This is because the harms of detecting and treating prostate cancer in older men consistently outweigh the benefits. The most common treatments, radical prostatectomy and radiation therapy, carry significant risks of urinary incontinence and erectile dysfunction. These are not trivial side effects for a man in his late 70s who is otherwise active and enjoying a full life. I remember James, a 78-year-old retired engineer from Chicago. His internist ordered a routine PSA test. It came back elevated. A biopsy confirmed low-grade prostate cancer. Standard clinical pathway led to radiation. 2 years later, James was wearing incontinence pads and dealing with ongoing bowel problems from the radiation. He told me, "Doctor, I had no symptoms. I felt fine. I wish I had never taken that test." Research published in the New England Journal of Medicine following thousands of men over 70 found that active surveillance produced identical survival outcomes to immediate treatment for low-grade prostate cancer. Identical. The men who were observed rather than treated maintained their quality of life. The men who were treated did not live longer. They just lived differently, and often worse. For men over 75, the discussion about PSA screening should happen with full transparency about what a positive result is actually likely to mean and what the treatment pathway would involve. Too often, that conversation never takes place. Have you or a man you love been through this? Type your experience in the comments below. These stories matter, and I read every single one, and now we arrive at number 1. The routine exam that I believe causes more unnecessary suffering in adults over 70 than any other. Routine mammograms for women over 75 with no symptoms and no family history of breast cancer. Before I say anything else, I want to be absolutely clear. Mammography is a life-saving tool. For women in their 40s, 50s, and 60s, screening mammography has demonstrated genuine mortality reduction benefits. I am not suggesting that mammography is bad. I am saying that the benefit to harm calculation shifts dramatically at age 75 and beyond, and most women are never told this. Here is the science. A landmark analysis published in the New England Journal of Medicine examined mammography outcomes across age groups and found that overdiagnosis, meaning the detection of breast cancers that would never have caused symptoms or death, rises sharply after 70. In older women, as many as 50 to 60% of screen-detected breast cancers are overdiagnosed. These are cancers that would have remained clinically silent for the rest of the woman's natural life. Now consider what happens when those cancers are found. Surgery, often chemotherapy, radiation, hormone therapy for years. Every one of those treatments carries risks that are amplified in older women. Surgical complications are more common after 70. Chemotherapy side effects are more severe and recovery is slower. Radiation therapy near the heart becomes more dangerous as cardiac reserve decreases with age, and the anxiety, the terror that comes from hearing the words, "we found something." In a 78-year-old woman, that fear can be genuinely life-altering, even when the final diagnosis is something that would never have hurt her. The United States Preventive Services Task Force has acknowledged that the evidence for mammography in women over 75 is insufficient. Several major medical organizations have called for individualized decision-making rather than blanket annual screening in this age group. The American Geriatric Society specifically recommends against routine cancer screening in adults with limited life expectancy or significant other health conditions. I remember Barbara, a 77-year-old retired nurse from Boston. She had her mammogram every single year. She trusted the system because she was part of it professionally for decades. The year she turned 77, the mammogram showed a small mass. Biopsy confirmed early-stage breast cancer, surgery, hormone therapy, annual surveillance for 5 years. When she came to me for a second opinion, she asked me a question that I think about often. She said, "Dr. Hayes, given my age and my other conditions, was treating this going to help me live longer or just change how I lived?" That is the right question. And the honest answer, based on the evidence for her specific tumor type and age, was that the survival benefit was likely minimal. What was certain was the disruption to her remaining years. This is not a reason to refuse all mammograms after 75, but it is an absolute reason to have a full conversation with your physician about your individual risk, your life expectancy, your other health conditions, and what you would actually do with a positive result before you agree to the screening. The power in medicine is not just in the test, the power is in the conversation before the test. Now let me tell you exactly how to implement what you have learned today. Start at your next doctor visit, not next year, but the next appointment you have. Come with a list. It can be as simple as 4 questions written on a piece of paper. First question, what specific benefit does this screening offer me at my age and with my health history? Ask for numbers. Ask for percentages. A good doctor will welcome the question. Second question, what are the harms and risks of this screening, including false positives and the downstream procedures they might trigger? The medical term for this cascade is downstream harms. You deserve to know about them. Third question, what is the chance that if this test finds something, I would benefit from treating it given my age and overall health? This is the overdiagnosis question. It is the most important one. Fourth question, what would we do differently if we skip this screening? Sometimes the honest answer is nothing. We would just watch for symptoms. And if that is the answer, the test may not be necessary. Write those questions down right now. Put them in your phone. Take them to your next appointment. Within your first conversation using these questions, you will know whether your doctor is giving you shared decision-making or just running the standard checklist. A doctor who welcomes your questions and engages with the evidence is a doctor who respects your autonomy. That is the kind of care you deserve. Here is my challenge to you. Before your next scheduled screening, whether it is any of the 6 we discussed today, commit to asking at least 2 of those questions. Just 2. Notice what happens. Notice whether the conversation changes. You are not broken. The system is not entirely broken either, but it was built for efficiency, not always for wisdom. The wisdom is yours to claim. I remember an exchange with Barbara, the retired nurse from Boston, near the end of our conversation. I told her that the most powerful thing she could do going forward was to stop being a passive recipient of medical procedures and start being an active participant in her own care. She smiled and said, "I spent 40 years telling my patients to ask questions. I forgot to ask them myself. Do not make that mistake. You have the right to every piece of information that informs your care. So let us recap what we covered today. 6 routine exams that deserve a serious second look after 70. Number 6, annual full-body skin checks for average-risk individuals with no history of skin cancer. Number 5, routine thyroid ultrasound and aggressive treatment of small findings. Number 4, echocardiograms ordered without symptoms or clear cardiac risk factors. Number 3, Pap smears and cervical cancer screening after 65 or following hysterectomy. Number 2, PSA screening for prostate cancer in men over 75. And number 1, routine mammograms in women over 75 without symptoms or high-risk features, ordered without a full conversation about the overdiagnosis evidence. Each of these screenings has its place. Each can save lives in the right population, at the right age, with the right risk profile, but applied without thought, without individualization, without honest conversation, they can cause real harm to real people. My message is not fear. My message is not that the medical system is your enemy. My message is empowerment. You are not a passive body to be screened on a schedule designed for the average patient. You are an individual with your own history, your own values, your own goals for your remaining years. You deserve care that reflects that. Here is my final challenge. Share this video with one person you love over the age of 70, one person who has a doctor appointment coming up, one person who has been worried about a test result. One conversation from this content could give them tools they need to navigate that appointment with confidence and clarity. If this video helped you, hit that like button. Subscribe to this channel for more real health information designed for adults over 60, and leave a comment below. Which of these 6 screenings surprised you most? Which one will you bring up at your next appointment? Because remember, aging does not take away your right to ask questions. It does not take away your body's ability to benefit from the right care, thoughtfully chosen. It simply reminds you that your time is precious, and the decisions you make about your health deserve to be made with full information. Take care of yourself.